Hello students, good evening. I am Dr. Raviraj, your anatomy faculty in Marrow. Now welcome to the clinical age discussion in the anatomy. Now in this session we are going to discuss certain clinical questions. Now in these questions we don't have any options. So we are going to discuss what are all the possible questions will come from that clinical question. And second thing, I am going to change some modifications in that question. So if I change that, then the answer, what are the other possible questions and answers we will get by the change. That is what we're going to discuss. Okay. So without wasting any time, we're going to the first question. The first question will be from the neuroanatomy. Now see this question. A 68-year-old male presents in the emergency room with nystagmus and dizziness. Examination reveals loss of pain and temperature sensation over the right side of the face and the left side of the body. The patient also exhibits ataxia and intentional tremors on both limbs. Patient is also having right eyelid droop and the small pupil. In addition, he is having hoarseness of voice. So first, what are the possible questions you will get from this clinical stem? They will ask you what is the condition the patient is suffering from, what syndrome? Lateral pontine syndrome or lateral medial syndrome or midbrain syndrome or medial midbrain syndrome, medial pontine syndrome. So you will get the question. The second possible question is, what is the artery involved in the syndrome? So first we have to know the syndrome. Now in this case the patient is having nystagmus and dizziness. Clue number 1. He is also having loss of pain and temperature sensation over the right side of the face and the left side of the body. Which means that the patient having loss of pain and temperature in the face means, yes, very good. The pain sensation, pain and temperature sensation from the face is carried by trigeminal nerve. Now we know that the trigeminal nerve involvement means we have to localize a lesion to lateral side, only lateral side. Now any cranial nerve involvement, the same side involvement will be there. Loss of pain and temperature in the right side of the face means then right side trigeminal. So from this clue, yes, we are getting right lateral. Lesion is in the right side lateral aspect. And loss of pain and temperature in the left side of the body. Loss of pain and temperature in the body means, very good, spinothalamic tract is affected. Whenever there is spinothalamic tract lesion, the effect will be on the opposite side. Loss of pain and temperature in the left side means right side spinothalamic tract is affected. So spinothalamic tract again, yes, again right lateral. Patient also exhibits ataxia, intentional tremors, that is patient is having involvement of spinocerebellar tract. Again spinocerebellar tract also in this side, yes, in a side means lateral, and right eyelid droop and small pupil. This is a feature of, very good, Horner syndrome. Very good, Horner syndrome. So he's having Horner syndrome. Again Horner syndrome, yes, sympathetic system involvement. Sympathetic system, yes, yes means side means lateral. So from these clues, yes, the patient is having right side lesion on the lateral aspect. Now still we don't have any idea about the brainstem involvement. Which part of brainstem is involved? Whether midbrain or pons or medulla, no idea. Now the last clue we have is the patient is having hoarseness of voice. So hoarseness of voice is due to vagus nerve. Now we know already 9th nerve, 10th nerve, 11th nerve, 12th nerve. These 4 nerves present in the medulla. Very good. So the lesion is, the syndrome is right lateral medullary syndrome. Now see the lateral pontine syndrome. Now lateral pontine syndrome also, vestibular nucleus involvement will be there. He is also having nystagmus, no? See here, nystagmus, dizziness. Lateral medullary syndrome, we have the nystagmus and dizziness. Same, lateral pontine syndrome also, nystagmus and dizziness will be there. Spinothalamic tract involvement, contralateral pain and temperature. Even in lateral medullary syndrome, we have this. Spinal nucleus of trigeminal, ipsilateral loss of pain and temperature. Even in that, yes, we have the involvement. Sympathetic tract involvement, yes. So these are all the common features. Even in the lateral medullary syndrome, you see these 4 structures involved. So we have to look for cranial nerve involvement. If it is 9th nerve, 10th nerve, 11th nerve and 12th nerve, the lesion is in medulla. If it is 5th nerve, 6th nerve, 7th nerve, 8th nerve, then the lesion in the pons. Okay. Now in the case of lateral medullary syndrome, the patient will have hoarseness of voice, dysphagia. Now mnemonic is, I told you, Pikachu is a mnemonic. That means Pica's artery involved in the lateral medullary syndrome, and Pica can't chew. Why? Because he is having dysphagia. Now vagus nerve involvement, yes, hoarseness of voice will be there. Now this is a feature of our lateral medullary syndrome. Now what is the artery involved? Please remember, artery involved is vertebral artery greater than Pica. Pica is answer, but best answer is vertebral artery greater than Pica. Now what about the lateral pontine syndrome, sir? The lateral pontine syndrome, the differentiating feature is facial is a mnemonic. Facial means AICA. ICA artery is involved. Lateral pontine syndrome. Again, which nerve is involved? Facial nerve is involved. Facial nerve involved means patient have facial muscle paralysis. Same side facial muscle paralysis will be there. I told you 5, 6, 7, 8. See, fifth nerve you should not consider, because fifth nerve have nucleus in all the levels of brainstem, midbrain, pons and medulla. We have to consider seventh nerve and eighth nerve. Okay, so seventh nerve, yes, ipsilateral facial muscle palsy will be there, and eighth nerve, yes, the patient will have deafness. Okay, so lateral pontine syndrome and the lateral medullary syndrome, they look similar. The only thing is the cranial involvement, seventh nerve, eighth nerve, then that is our lateral pontine syndrome. Eighth nerve, mainly cochlear nucleus. Okay, right. Now what about lateral medullary syndrome? Yes, dysphagia will be there, hoarseness of voice will be there. This is the differentiating feature from these two syndromes. Now what is the answer for this question? This is our lateral medullary syndrome. And what is the artery involved? Vertebral artery greater than Pica. Very good. Now I told no, the same stem only, the patient is having nystagmus, dizziness, loss of pain and temperature over the right side of the face, left side of the body, also exhibits ataxia, intentional tremors, right eyelid droops, small pupil, up to this same stem only, same question only. Now the clue is changing from here. He's having right side facial drop, loss of corneal reflex, loss of hearing. This is our lateral pontine syndrome. Lateral pontine syndrome. Again, what is artery involved? ICA artery is involved. Okay, right. Now see the next question. Now the 15-year-old boy is hit in the temple with a baseball and he became unconscious. After 10 minutes, he regained the consciousness, but he becomes lethargic, and over next 2 hours, he becomes stuporous and his pupils are unequal. Intracranial hemorrhage is suspected. Now, what is the hemorrhage? Now, for this, you have to know some basics about intracranial hemorrhage. See, mainly we are going to discuss two things. One is our epidural hemorrhage and the subdural hemorrhage. Epidural hemorrhage and subdural hemorrhage. Okay? Right. Now, see this diagram. Now, this is the diagram showing the skull and the meningeal layers, and also we are seeing the final drainage of CSF into the subarachnoid space. Now, this is the brain. Now, very close to the brain, we are seeing the pia mater. Above the pia mater, we are seeing the arachnoid membrane. Now, above that, we are seeing the dura mater. Right. Now, between the arachnoid mater and the pia mater, we have the CSF. Now, CSF through arachnoid granulation, which is draining into dural venous sinus. Fine? Good. Now, here we have a space between the dura mater and the arachnoid membrane, that is subdural space. Now, what is present in the subdural space? Very good. Bridging veins is present. Bridging veins present. Now, in the epidural space, one artery is there. That is our middle meningeal artery. Now, middle meningeal artery, in the exams, in the INACT exam and also the NEET exam, they are asking repeatedly about their location. See, middle meningeal artery is located just beneath the pterion. Pterion is a meeting point of 4 bones. Frontal bone, parietal bone, and then temporal bone and the sphenoid bone. That is a pterion. Just beneath the pterion, we see the middle meningeal artery. Now, in the exam, last year, 2022 INACT exam, they asked you specifically which branch of middle meningeal artery is present. Please remember, frontal branch of middle meningeal artery or anterior branch of middle meningeal artery is present beneath the pterion. Specifically, they will ask you. Okay. Now, middle meningeal artery involvement, I told you, which in turn leads to epidural hemorrhage. Now subdural hemorrhage is due to venous hemorrhage, our bridging veins. So epidural hemorrhage and the subdural hemorrhage we have. Now next question is, now they may ask you about the CT image. Now in the CT, now non-contrast CT, how to differentiate epidural hemorrhage and the subdural hemorrhage. Please remember, the epidural hemorrhage or subdural hemorrhage will be lens shape or biconvex shape. Now what about the subdural hemorrhage? Subdural hemorrhage, the non-contrast CT, it will be C shape or crescent shape. Is that fine? Good. Now, yes, these are the possible questions you will get from this topic. Now, see the clinical stem. Now, here they gave the patient, he became unconscious initially. Later, he regained the consciousness. And finally, after some time, some period of time, from few minutes to few hours, again he became lethargic and unconscious. Now, in this clinical stem, yes, they are mentioning about lucid interval. Please remember, lucid interval, it is seen in both epidural hemorrhage and the subdural hemorrhage. Now we have two answers. Now what is the best answer, sir? Epidural hemorrhage greater than subdural hemorrhage. That is the best answer. Epidural greater than subdural. Clear? Good. Now, so intracranial hemorrhage is suspected. So in the options, if they give epidural hemorrhage, yes, that is the best answer. If epidural hemorrhage is not given, then you have to go for subdural hemorrhage. Very good. Now what is the artery? Instead of artery, they can give you what is a vessel. So what is the vessel involved here? In the epidural hemorrhage, middle meningeal artery. Now what is the vessel involved in the subdural hemorrhage? Bridging veins. Now the CT image, yes, I told you, it is a lens shape or biconvex shape for epidural hemorrhage. Subdural hemorrhage, yes, it is C shape or crescent shape. Now 40-year-old female graduate student has exuberating headache. When she looked in the mirror, she noticed her eyelid was drooping. When she lifted the eyelid, she saw that eyelid was looking down and out, and pupil was huge. She also having eyelid droop. She complained of both blurred vision and double vision. An MRI scan showed that aneurysm of cerebral arterial circle. What is the artery involved in that? So now they are asking about the artery involved in this clinical condition. Now here again we are seeing the subarachnoid hemorrhage. Now the patient is having aneurysm in the cerebral arterial circle. Now what are the artery involved here? Now this is circle of Willis. So blood supply of brain, we know already, brain is supplied by carotido-basilar system. Carotid means our internal carotid artery, and the basilar artery formed by vertebral artery. Very good. Now the internal carotid artery gives middle cerebral, anterior cerebral, and the posterior cerebral artery, a terminal branch of basilar. Now posterior cerebral joining with internal carotid via posterior communicating, and the two anterior cerebral, they are connected by means of anterior communicating. So anterior cerebral, anterior communicating, internal carotid, posterior communicating, and posterior cerebral, all these arteries they anastomose with each other and they form circle of Willis. Is that clear? Right. So now again old question, they are asking about what is the artery not involved in the circle of Willis. The artery more on the lateral side. What is the artery more on the lateral side? Our middle cerebral artery. Middle cerebral artery is not involved in the circle of Willis. Okay. Now come to the question. Now in this question, yes, in this diagram we are seeing the posterior communicating artery, and we are seeing the aneurysm of posterior communicating artery, and very close to that you are seeing one nerve here, and that is our oculomotor nerve, third nerve. Okay, so third nerve is very close to our posterior communicating artery. So whenever you see aneurysm of our posterior communicating artery, which structure will be compressed? Third nerve will be compressed. If third nerve is compressed, then what are the features you have to remember? I told you mnemonic in the module. Mnemonic is P, PD, PDO. That is, the patient will have ptosis, pupils will be dilated, and the eyeball will be down and out, dilated. These are the features of our third nerve injury. Now along with that, patient also have loss of two reflex, loss of accommodation reflex and loss of light reflex. Okay, right. Now another possibility is, now anterior communicating artery also go for aneurysm. Anterior communicating artery also go for aneurysm. Now in the case of aneurysm of anterior communicating artery, which structure will be compressed? Very good. Our optic chiasma is compressed. Now what is the clinical feature if optic chiasma is compressed? Very good. Optic chiasma compressed means then the patient will have bitemporal hemianopia. Bitemporal hemianopia. That is the feature. Okay, right. Now again this question they gave in the NEET exam, 2021 NEET exam, we got this question. The aneurysm of anterior communicating artery they gave. Optic chiasma will be compressed. Okay. Now what is the answer for this question? What is the artery affected in this condition? Now patient is having eyelid droop, ptosis, and pupils are dilated, and eyeball is down and out dilated, down and out. Okay, now the answer for this question is third nerve is affected. Now when the third nerve will be affected? Very good. Due to the aneurysm of posterior communicating artery. Now see the next question. A 50-year-old male came with the complaints of right-sided weakness and left eye down and out dilated. So now in this condition they are asking about the syndrome. What syndrome? What is the syndrome? Now you have to know the structures involved in this syndrome. Now if you know about this syndrome, then two other syndromes are there associated with the midbrain. Now why I am saying midbrain? Because he is having the third nerve involvement. So third nerve involvement means third nerve, fourth nerve, they are present in midbrain. Now what are the structures involved in this syndrome? Now what are the other syndromes arising from midbrain? That is what we are going to discuss in this clinical STEM. Now before proceeding, now see this. Now this is the image of the midbrain at the level of superior colliculus. So midbrain section we are seeing at the two levels, superior colliculus and the inferior colliculus. Now this is section taken at the level of superior colliculus, right? Now in the superior colliculus, you see the red nucleus and also the third nerve. Yes, this is third nerve. And please note down, here we are seeing the corticospinal tract also passing. That will be there in the midbrain, even at the level of inferior colliculus. The special structure, what you see at the level of superior colliculus is third nerve and red nucleus. And lemniscus also we see only, three lemniscus only. Medial lemniscus, trigeminal lemniscus, and the spinal lemniscus. The lateral lemniscus is not seen at the level of superior colliculus. Lateral lemniscus you see only at the level of inferior colliculus. Now another important point is at the level of inferior colliculus we see trochlear nerve. Midbrain at the level of inferior colliculus, trochlear nerve, and we also see the decussation of superior cerebellar peduncle. The superior cerebellar peduncle after crossing, which in turn comes to red nucleus, which in turn end in red nucleus, and they also go superiorly above the red nucleus and they end in thalamus. This is a very important point. You have to know this. So superior cerebellar peduncle, 2 points I told you. They decussate in the midbrain at the level of inferior colliculus. After the crossing, they go to red nucleus and thalamus. Please don't forget. Right, now we're going to write the syndromes. Now in the midbrain, we have to remember Weber syndrome. Weber syndrome is very simple. Third nerve involvement plus corticospinal tract involvement. That's all. I told you, any cranial nerve involvement, the effect will be on the same side. Third nerve involvement, the patient will have same side involvement. Corticospinal tract involvement means the effect on the opposite side. Opposite side hemiplegia will be there. This is Weber syndrome. Okay. Now what about the Claude syndrome, sir? Now in the Claude syndrome, again same third nerve involvement will be there plus red nucleus. Now just now I told you red nucleus is receiving the superior cerebellar peduncle. If red nucleus superior cerebellar peduncle affected, then the patient will have contralateral ataxia. Very important point. Okay. Now we have one more syndrome. What is that? Benedict syndrome. Now in the Benedict syndrome, what are structures affected? See, Benedict syndrome very simple. Weber syndrome plus Claude syndrome plus involvement of subthalamus. That is our Benedict syndrome. So what are structure affected the Benedict syndrome? Third nerve plus corticospinal tract. Again Claude syndrome, third nerve plus red nucleus, superior cerebellar peduncle plus subthalamus. Now subthalamus involvement, which in turn leads to, very good, hemibalismus. That is a question we got last year, 2022 NEET exam question. Ballistic involvement of the upper limb and lower limb due to involvement of which are the following structure? 2022 NEET exam question. Okay? Right. So these are the points you have to know about the brainstem syndromes. Right. Now what is the syndrome? Yes, this is our Weber syndrome. What are structure affected the Claude syndrome? I told you, third nerve involvement, red nucleus plus superior cerebellar peduncle. Benedict syndrome, third nerve, corticospinal tract, superior cerebellar peduncle, red nucleus plus subthalamus. Okay? Right. Now that's all about this question. Come to next question. Now the next question, yes, this diagram is very important diagram. Very often we are getting this question, and this section, yes, we are getting. Now see the question. The woman with right side loss of sensation of both upper limb and lower limb complains of shooting pain from her fingers to the right shoulder and burning sensation when touching the cold water. Motor functions are normal. Very important. Which are the following structure likely to get affected? This is the question. Okay. Right. So now in the clinical stem, yes, the clinical features are suggestive of thalamic syndrome. Very good. The patient is having thalamic syndrome. So thalamic syndrome features is having the over sensation, shooting pain from the fingers and burning sensation when touching the cold water. Hypersensitivity will be there. And very important clue, yes, thalamic syndrome, no motor involvement. Motor functions are normal. So in this section, they are asking us to identify, yes, the thalamus. Now this is the cut section image. This is anterior. This is posterior. So now in the midline, you have the cavity. This cavity is our third ventricle. Third ventricle is a midline cavity. Just opposite to that, you see the nucleus F. Yes, that is our thalamus. Okay. Now that is the thalamus means then this entire structure, this one I am talking about, these two structures. These two structures are our lentiform nucleus, and above that, this A is our caudate nucleus. Okay. Now what are the parts of lentiform nucleus? I told you this is a lentiform nucleus. Now what are the parts of lentiform nucleus? Now lentiform nucleus, yes, this is B, and B is our putamen. And this one inside, no, and that is our globus pallidus. Right. Now what about C? See, C, D, E. These are the white matter present between caudate nucleus, lentiform nucleus and the thalamus. Okay. Now C is the anterior limb of internal capsule. E is posterior limb of internal capsule. And D is genu of the internal capsule, and F is the thalamus. So internal capsule, where you see the internal capsule? Internal capsule is present between caudate nucleus and the thalamus medially, and lentiform nucleus laterally. Very important. Don't forget, don't forget, don't forget. Shall we proceed? Right. Now where you see the anterior limb? Anterior limb is present between caudate nucleus and lentiform nucleus. What about the posterior limb? Between thalamus and the lentiform nucleus. Now between anterior limb and posterior limb, we see genu. Fine. So now, yes. So these are structures you have to identify. Very good. Now come to next image. Now another important image, very often we are getting the question about, yes, this structure. Now this is the coronal section of the brain. Now in this coronal section, yes, they will mark you this, mark this structure. Now this is our third ventricle. I told you third ventricle is a midline slit. That is our third ventricle. On either side of third ventricle, this is our thalamus. Now below the thalamus, now this is our midbrain. This is our pons. And this is our medulla. Midbrain, pons and medulla. Now in the midbrain, we are seeing the black pigmental structure. That is what is marked as A. That is our, very good, substantia nigra. Now, substantia nigra contains black pigment, melanin. Melanin is the precursor for dopamine. So, lesion in the A, this is a marked structure which in turn leads to Parkinson's disease. Parkinson's disease. Now, Parkinson's disease, which is also known as paralysis agitans. Now, what is the clinical feature of the Parkinson's disease? The patient will have rigidity. Patient will have rigidity. Hypokinesia. Hypokinesia means failure to initiate the movement. And the patient also have resting tremors. Very important point. So, resting tremors is a feature of Parkinson's. See, I am saying only main features. Apart from this, the patient will have mask-like, expressionless face, shuffling gait. So many features are there. But I am saying only main features of Parkinson's. So, resting tremors feature of Parkinson's disease. Now, what about the kinetic tremors? They give you this. Kinetic tremors, yes, very good. They are the features of cerebellar lesion. They are the feature of cerebellar lesions. Fine. Okay. Right. So, now what is the answer for this question? For thalamic syndrome? Yes. Identify thalamus. Thalamus is our F. Thalamus F. Right. That's all about this question. Now, come to next question. The patient knows what he wants to speak, but he cannot. Now, what are the questions you will get? What are the areas affected? What is the number for that area? Now, if they change the area, sometimes instead of giving this area, sometimes they may mark the B here. And they will ask you if a lesion in B leads to. And we have to know one more important differential diagnosis. We have to know about conduction aphasia. Okay. So, now patient, he knows what he wants to speak, but he cannot. That means, what is the structure affected? Which area of the cerebrum is affected? So, patient comprehension is good. He is not able to give reply. That means, fluency is gone, but comprehension is good. So, fluency gone and the comprehension is good and the repetition for this case also gone. Now, this is the lesion over the Broca's area. The patient is having Broca's aphasia. Aphasia, it is a language disorder involving the dominant lobe. So, what is the area affected? So, Broca's area, it is situated in, very good, inferior frontal gyrus. Question, old NEET question, 2018, very old question. What is the number for this area? Broca's area number 4445. Now, what about the vernix area? Now, vernix area, it is lesion in B, vernix area. Now, vernix area located in, vernix area is located in the posterior end of superior temporal gyrus. Now, what is the number? Area number 22. Vernix area is the sensory area for speech. Now, what will be the clinical feature? If the vernix area is affected, patient comprehension, no, comprehension is gone in the vernix aphasia. Fluency, yes, and repetition is gone. Now, with the vernix aphasia, I told you in the main module, paraphasia and neologisms are present. Paraphasia means he will replace one word for the other, and neologisms, he create one new word for that. Okay? Right. Now, what is conduction aphasia? See, conduction aphasia is due to involvement of this fasciculus, which in turn result in the conduction aphasia. So, in conduction aphasia, vernix area normal, comprehension is normal, Broca's area normal, fluency is normal, but both of them are not connected, so repetition is gone. That is a feature of conduction aphasia. Okay. So, now we got answer for all these questions. So, what is the area affected? Broca's area, inferior frontal gyrus, functional number 4445, lesion in B leads to vernix aphasia, and what is the conduction aphasia? Due to lesion in the arcuate fasciculus. Clear? Now, in the next image, yes, the 50-year-old male presents with fever and trismus. The oropharyngeal examination is given below. There is also swelling in the neck at the upper border of sternocleidomastoid muscle. Now, what are the possible questions you will get? Now, where is the infection? Now, if infection means, then what is the content of that infected space? And what is the boundary of that space? Medial boundary, lateral boundary, superior, inferior. Now, what are the other possible differential diagnoses? Okay, these are the questions we are going to discuss in this question from this clinical stem. Now, the tonsil here we are seeing the tonsil which is displaced more medially, medial displacement of tonsil. Plus, we also have the swelling in the neck. They also gave clue that patient is having swelling in the neck, in the upper border of sternocleidomastoid muscle. So, medial displacement of tonsil and the swelling in the neck, this is mainly suggestive of, very good, parapharyngeal space infection. Parapharyngeal space infection. Infection in the parapharyngeal space. Now, what is the boundary for the parapharyngeal space? See here, this is a parapharyngeal space. Now, this is the medial side and this is a lateral side. This is superior. This is inferior. So, superiorly, we have the base of skull. Inferiorly, hyoid bone. Laterally, mandible. The mandible, ramus of mandible, specifically seeing. And the ramus of mandible receiving the masseter. Okay, medial pterygoid. Plus, we also see one gland, our parotid gland. Now, what about the medial boundary? Medial boundary will be the lateral pharyngeal wall. I told you, infection in this space. What will happen? Which in turn push the tonsil to the medial side. Tonsil will be displaced medially. Plus, you also see the neck swelling. Now, what are the contents of this space? So, contents of this space, please remember internal carotid artery, internal jugular vein, and the last 4 cranial nerves, 9th nerve, 10th nerve, 11th nerve, and 12th nerve present in this space. Okay. Now, what is the differential diagnosis for this condition? Let's see the diagram. Now, in this diagram, yes, we are seeing the tonsil, that is lateral wall of tonsil we are seeing. Now, in the lateral wall of tonsil, yes, tonsil is covered by the capsule. This is our capsule. Now, next to the capsule, we have a space. That space is called our peritonsillar space. Peritonsillar space. Now, in the peritonsillar space, we are seeing the vein, paratonsillar vein. This one, that is our paratonsillar vein. Okay, right. So, now paratonsillar vein, yes, it is the main source of hemorrhage after the tonsillectomy procedure. 2021 INACT question. Okay, right. Now, the other possible questions are, now which muscle is forming the bed of tonsil? See, bed of tonsil is formed by, tonsil is lying over one muscle. Which muscle? Very good. Our superior constrictor muscle. Now, tonsil is lying over the superior constrictor muscle. Okay. Now, another important structure is, you have to remember this 5. 5 is nothing but our glossopharyngeal nerve that is present lateral to the superior constrictor muscle. Okay. Right. Now, why you have to know this? Now, glossopharyngeal nerve, it is a nerve supplying the tonsil. The same glossopharyngeal nerve also supplies our middle ear. Whenever there is a tonsillitis, the pain referred to middle ear. Why, sir? Because glossopharyngeal nerve gives tympanic branch of glossopharyngeal nerve and found tympanic plexus supply the middle ear. 2023 NEET exam question. The same question was given in old FMG exam. 2020-21 FMG. I forgot the year. Subject to correction. They gave this question. Now, damage to the glossopharyngeal nerve during the tonsillectomy procedure, then the pain will be referred to. Again, glossopharyngeal nerve damage means, yes, there is a main nerve supplying the middle ear. Pain will be referred to middle ear. So, first they gave this question in FMG and they repeated in the NEET exam. Okay, right. Now, these are the possible questions you will get from this. Now, here in the peritonsillar space, now the patient may have some infection. Now, in the peritonsillar space, yes, the patient may have some infection. Now, in this case, the tonsil will be displacing more medially. Sir, even for parapharyngeal space, he told the same thing, sir. Yes. Then what is the difference, sir? Here, the infection in the peritonsillar space, only you will see the medial displacement of tonsil. Here, no neck swelling. Now, infection in the peritonsillar space is called quinsy. Don't forget, don't forget, don't forget. So, quinsy is an infection in the peritonsillar space. The tonsil will be moving medially, but no neck swelling. Very, very, very important. Okay, right. Yes, what is the infection? That is infection. Infection in the parapharyngeal space. Content I told you, internal carotid artery, internal jugular vein, and the last 4 cranial nerves. Boundary, I told you. Differential diagnosis, Quincy. Now, CA nasopharynx is most commonly seen in. CA nasopharynx is most commonly seen in our fossa of Rosenmuller. Yes. One-liner. Try to know answer for this. Right. Now, next one. See the next question. The surgeon, while clearing the lymph nodes in neck, mistakenly damaged the superior laryngeal nerve in the carotid triangle. So, this is a clue. Now, we get so many questions from this clue. What are the nerves affected? Muscle or muscles affected? Any sensory loss? Now, is there any artery accompanying the damaged nerve? Yes. So many questions are there. Now, please remember this clue. Superior laryngeal nerve in the carotid triangle, which is dividing into external laryngeal nerve and the internal laryngeal nerve. That is very, 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 very important. Okay. So, superior laryngeal nerve only in the carotid triangle divided into internal laryngeal nerve and the external laryngeal nerve. Please remember, superior laryngeal nerve, it is a branch of vagus nerve. It is arising from vagus nerve at the level of skull base itself. From the skull base itself, superior laryngeal nerve will arise. When after reaching the carotid triangle, which is dividing into external branch and the internal branch. External branch, it is the purely motor branch, which supplies only one muscle, cricothyroid. And the internal laryngeal nerve is purely sensory nerve, which carries sensory fibers from the larynx above the vocal cord. Okay, right. Now, the external laryngeal nerve supplies cricothyroid muscle. Now, what is the action of cricothyroid muscle? Cricothyroid muscle have two actions, tensor greater than adductor. In the anatomy books, they mention only about the tensor property of this muscle. In the ENT books, they add the adduction property also for the cricothyroid muscle. So, we write both answers, tensor and adductor, but best answer is tensor greater than adductor. Okay, right. Now, this external laryngeal nerve, see here, which is closely related to our superior thyroid artery. So, ligation of superior thyroid artery. Now, structure affected during the ligation of superior thyroid artery is our external laryngeal nerve. Okay, right. Now, what about the internal laryngeal nerve? See, internal laryngeal nerve, it is a sensory nerve, I told you, which carries only sensory fibers to the larynx above the vocal cord. Now, what about sensory supply of larynx below the vocal cord, sir? Who will carry? Recurrent laryngeal nerve. Now, the recurrent laryngeal nerve course is not same in the right side and left side. Now, the right recurrent laryngeal nerve, it is arising. See here, this is the right recurrent laryngeal nerve is arising at the level of right subclavian artery. Whereas left recurrent laryngeal nerve is arising at the level of arch of aorta. Again, whenever they want to ask any clue about the recurrent laryngeal nerve injury, they will ask you, they will give you this clue. The surgeon mistakenly damaged the structure which is passing in the tracheo-esophageal groove. Very, 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 very important clue. Tracheo-esophageal groove means only one structure of a recurrent laryngeal nerve damage. Now, recurrent laryngeal nerve damage means recurrent laryngeal nerve supplies all the muscles of larynx. All the muscles of larynx except, very good, our cricothyroid. And it also carries sensory fibers from the larynx below the vocal cord. Below the vocal cord. Okay, right. So, now see this diagram. I told you right recurrent laryngeal nerve is arising at the level of right subclavian artery and the left recurrent laryngeal nerve arising at the level of, yes, arch of aorta. Fine. Super. Now, in the exam, they will ask you which is the most commonly affected recurrent laryngeal nerve. The most commonly affected recurrent laryngeal nerve is left recurrent laryngeal nerve greater than right recurrent laryngeal nerve. Why, sir? Because the left recurrent laryngeal nerve is having longer course. It is having the course in the mediastinum and also in the neck. Because arch of aorta, it is a mediastinal structure. It is present in the superior mediastinum. Okay, so left recurrent laryngeal nerve is available for more space, so more commonly that will be affected than the right side. Okay, So now see the question. The surgeon, while clearing the lymph node in the neck, mistakenly damaged the superior laryngeal nerve in the carotid triangle. So what are the nerves affected? Yes, internal laryngeal nerve and the external laryngeal nerve. Now what are the muscles affected? Only one muscle. Which muscle? Cricothyroid muscle. Is there any sensory loss? Yes, sensory loss of larynx above the vocal cord. Yes. What is structure accompanying superior thyroid artery? External laryngeal nerve. What is structure accompanying inferior thyroid artery? Recurrent laryngeal nerve. Recurrent laryngeal nerve is passing in which groove? Tracheo-esophageal groove. These are the various questions you will get from this topic. Right. Now, next one. Now, a 46-year-old man visits the speech therapist complaining of dryness of mouth. The therapist performs a swallowing study and on examination finds that the man has a lack of salivary secretion from the submandibular gland. So now from this clinical stem, they can ask you so many questions. What is a ganglion involved in this? What are the nerves involved in the preganglionic pathway? Now what is a nucleus? Now if you know this, then you have to know the parasympathetic pathway for the parotid gland also. And one important applied, very important topic for the NEET exam is our Fraze syndrome. We discuss all this. Okay. Now first we're going to see the pathway for the submandibular gland. Now for submandibular gland, secretion is controlled by superior salivatory nucleus. Please underline this, superior salivatory nucleus. Now fibers from superior salivatory nucleus are carried by 7th nerve. Now from 7th nerve, the fibers are given to chorda tympani nerve. The chorda tympani nerve which is joining with lingual nerve. And the lingual nerve which in turn suspend the submandibular ganglion. And the submandibular ganglion which in turn supply the submandibular gland and sublingual gland. This is a pathway, a parasympathetic pathway for our submandibular gland. Now what is the nucleus? Nucleus is superior salivatory nucleus. What are the nerves involved in the preganglionic pathway? Now preganglionic pathway, this is submandibular ganglion. The preganglionic pathway, the nerve involved are 7th nerve, chorda tympani nerve and the lingual nerve. Now who will carry the postganglionic fibers to submandibular gland? Direct fibers from the submandibular ganglion supply the submandibular gland. Direct fibers from the ganglion. Clear? So now we know the nucleus, now we know the ganglion and we know the parasympathetic fibers, preganglionic parasympathetic fibers involved in this pathway. Is that clear? Right. Now what about the chorda tympani nerve? Now I want to add one more point to the chorda tympani nerve. It's very important for INACT exam. See, chorda tympani nerve is the one which carry the taste fibers from the anterior two-third of the tongue. So chorda tympani carries special visceral afferent fibers, SVA fibers. Okay, fine. Plus, the chorda tympani also carries preganglionic parasympathetic fibers. Now, what is the parasympathetic nucleus column? General visceral efferent. General visceral efferent is a parasympathetic column. Please don't forget. SVE is the column for pharyngeal arches. SVE. Pharyngeal arches column, special visceral efferent. GVE, parasympathetic column. So what are the nuclear columns involved in the chorda tympani nerve? SVA fibers and GVE fibers. Okay, right. That's all about this ganglion. And now we see the parotid gland. See, if you want a secretion from the parotid gland, the fibers have to start from inferior salivatory nucleus. Inferior salivatory nucleus. From there, the fibers are given to 9th nerve. Now from 9th nerve, the tympanic branch of 9th nerve. From there, the fibers are given to tympanic plexus. Now from tympanic plexus, yes, the fibers are carried by lesser petrosal nerve. Now from lesser petrosal nerve, fibers are given to otic ganglion. Now from otic ganglion, auriculotemporal nerve carry the fibers to the parotid gland. Now these are the nerves involved in the parasympathetic pathway for the parotid gland. Okay, what What is the nucleus? Inferior salivatory nucleus. Which nerve carrying the fiber? Preganglionic parasympathetic fiber, our glossopharyngeal nerve. Very important. Parotid gland secretion is controlled by our ninth nerve, glossopharyngeal nerve. Tympanic branch, tympanic plexus, lesser petrosal nerve. Okay. Which nerve carries postganglionic parasympathetic fibers? Our auriculotemporal nerve carries postganglionic parasympathetic fiber. Okay. Right. Now, one important applied is, now this auriculotemporal nerve will be damaged during the parotid surgery. Auriculotemporal nerve is damaged during parotid surgery. Now the fibers, auriculotemporal nerve will regenerate, which in turn supply the sweat glands. Instead of supplying the parotid gland, it is not supplying the parotid gland. Instead, it is supplying the sweat glands. Okay. Yes, this is about the Frey syndrome. So Frey syndrome is nothing but it is the gustatory sweating. Frey syndrome is due to involvement of which nerve? Auriculotemporal nerve. Please don't forget. These are possible questions you will get from this topic. Okay. Now what is a ganglion involved in this pathway? Very simple. Submandibular gland secretion. Yes, submandibular ganglion. Now what are the nerves involved in the preganglionic pathway? Seventh nerve, cauda tympani nerve, nucleus, superior salivatory nucleus, parasympathetic pathway for parotid. I told you, inferior salivatory nucleus, ninth nerve, tympanic branch of ninth nerve, tympanic plexus, lesser petrosal nerve, OT ganglion, and then auriculotemporal nerve, parotid gland. What is Frey syndrome? Auriculotemporal nerve damage during parotid surgery. The fibers will regenerate and supply the sweat glands instead of parotid. It won't supply the parotid. Instead, it supplies sweat glands. Okay? Right. So now we're going to start the next question. Now in this question, yes, the 30-year-old patient cannot flex the distal interphalangeal joint of the index finger. His physician determines that he has a nerve damage from the supracondylar fracture. Okay. Now, what are the possible questions you'll get? What is the nerve affected? And what are the muscles supplied by the injured nerve? Now, do you see any clinical sign? So many things to ask. Right. Now, first question is, now the patient is having supracondylar fracture. So, in the case of supracondylar fracture, the most commonly affected nerve is our anterior interosseous nerve greater than median nerve. Okay, anterior interosseous nerve greater than median nerve. That is the most common nerve affected in the supracondylar fracture. Now, any artery affected? Yes, we have artery involvement. What artery? That is our brachial artery. So, brachial artery is also affected in the supracondylar fracture. Now, brachial artery is a one divided into radial artery and the ulnar artery. So, radial artery, ulnar artery supply the forearm and also palm. Now, in the case of brachial artery laceration in the supracondylar fracture of the humerus, the patient have Volkmann's ischemic contracture. Volkmann's ischemic contracture. Okay, yes. So, please remember this point also. Right. Now, anterior interosseous nerve in the forearm supplies only 2.5 muscles. What are those? Our pronator quadratus muscle supplied by our anterior interosseous nerve. Flexor pollicis longus supplied by our anterior interosseous nerve. And flexor digitorum profundus. See, flexor digitorum profundus we are going to divide into two halves. Lateral half and the medial half. Medial half of FDP is a tendon to little finger and the ring finger. Lateral half of FDP means tendon to index finger and the middle finger. Lateral half of FDP is supplied by anterior interosseous nerve and the medial half of FDP is supplied by, yes, our ulnar nerve. Please don't forget. Okay. Yes. So, anterior interosseous nerve supplies 2.5 muscles. Very good. Now, the flexor digitorum profundus tendon which goes up to the distal phalanx. So, what is the action of FDP muscle? FDP muscle flex the wrist. FDP muscle flex the metacarpophalangeal joint. And FDP muscle flex the proximal interphalangeal joint. Now, FDP also flex the distal interphalangeal joint. Okay. So now our FDP muscle, it is crossing all these joints in the front side. So it is flexing all the joint, flexion of wrist, metacarpophalangeal joint, proximal and distal interphalangeal joint. Now one important muscle we have to know is our FDS muscle. See, flexor digitorum superficialis muscle. Now this muscle attached to middle phalanx. Now what is action? It is flexing the wrist, flexing the metacarpophalangeal joint, and flexing the proximal interphalangeal joint. So the only difference between FDP and FDS is, yes, very good, FDP flex extra one joint, flexion of distal interphalangeal joint. Okay. Now what are the muscles supplied by median nerve in the forearm? Median nerve directly supplies our pronator teres muscle, supplied by median nerve. Flexor carpi radialis, median nerve. Palmaris longus, median nerve. And FDS muscle supplied by median nerve. I told you, ulnar nerve supplies only 1.5 muscles in the forearm. What are those? Flexor carpi ulnaris supplied by ulnar nerve. And medial half of FDP supplied by our ulnar nerve. Clear? Any doubt? No. Right. So now anti-interosseous nerve, branch of median nerve, supplies 2.5 muscles. Our pronator quadratus, flexor pollicis longus, and FDP muscle lateral half. Okay, right. Now the clinical sign in the case of anterior interosseous nerve syndrome is, the patient in the case of anterior interosseous nerve injury, he will give abnormal OK sign. Now how the abnormal OK sign will look like? See, if you want to give OK sign, we have to flex the distal interphalangeal joint of the index finger and the thumb. Now FDP to the lateral half, and the flexor pollicis longus is supplied by our anterior interosseous nerve. In the case of anterior interosseous nerve injury, the patient is not able to flex the distal interphalangeal joint of the index finger, middle finger, and the thumb. So patient is not able to give perfect OK sign like this. He give OK sign like this only. He can flex only up to the proximal interphalangeal joint. Distal interphalangeal joint is not possible. Hand posture in the anterior interosseous nerve syndrome due to the palsy of FDP and flexor pollicis longus. The patient will give abnormal OK sign. So in the case of supracondylar fracture, yes, what are the possible questions you will get? What is the most common affected nerve? Anterior interosseous nerve greater than median nerve. What are the muscles supplied by anterior interosseous nerve? Anterior interosseous nerve, branch of median nerve, supplies 2.5 muscles. Now what is the sign in the anterior interosseous nerve syndrome? Yes, patient will give abnormal OK sign. Okay. Now next one. Now a 30-year-old male with a cubital tunnel syndrome complains of numbness and tingling sensation in the ring and the little finger and back and side of his hand because of damage to nerve in the tunnel in the elbow. So patient is having cubital tunnel syndrome. That is a clue. And another clue is they having numbness in the ring finger and the little finger. Which nerve, sir? Ring finger, little finger. Sensory supply. Medial 1.5 digits. Yes, very good. The nerve affected is ulnar nerve. So ulnar nerve affected in this. Ulnar nerve is passing behind the medial epicondyle. Behind the medial epicondyle. Please don't forget this. 2021 INACT exam, we got this question. So the structure related to the neck of the humerus bone. Surgical neck of the humerus bone. Axillary nerve. The structure related to the shaft of the humerus bone in the spiral groove. Radial nerve. Very good. The structure present behind the medial epicondyle. Ulnar nerve. Very good. So please don't forget these three nerves you have to remember. Now what are the muscles supplied by ulnar nerve in the palm and forearm? Now ulnar nerve supplies forearm, already I told you. Flexor carpi ulnaris and FDP medial half. Now what are the muscles supplied by the ulnar nerve in the palm? See, ulnar nerve supplies all the muscles in the palm except loaf muscle. These 4 muscles are supplied by our median nerve. Now opponens pollicis muscle, abductor pollicis brevis, flexor pollicis brevis, and the lumbricals 1 and 2. So these 4 muscles are supplied by our median nerve. Now in that OAF, these 3 muscles, they will form the thenar eminence. So patient may have thenar eminence atrophy. Patient may have thin arm atrophy. That means which nerve is affected? Yes, patient have median nerve injury. Opponens pollicis, abductor pollicis brevis, flexor pollicis brevis, they form thenar eminence. So thenar eminence atrophy means the patient is having median nerve injury. Now except these muscles, remaining all other muscles are supplied by our ulnar nerve, deep branch of ulnar nerve. Now what are the muscles supplied by ulnar nerve? Hypothenar eminence muscle. Now what are the muscles in the hypothenar eminence? Hypothenar eminence muscles are abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. These three muscles form hypothenar eminence. Plus lumbricals 3 and 4, palmar interosseous 4, palmar interosseous, dorsal interosseous 4, and this ulnar nerve also supplies adductor pollicis. So if you want, you can remember this or simply remember loaf muscle. Except loaf muscle, all other muscles are supplied by our ulnar nerve. Is that clear? Right. Now, what is the sensory supply? Ulnar nerve supplies medial 1.5 digits. Don't forget, in the palmar side. Now, one important sign we have to note for the ulnar nerve is Froment sign. Now, in the Froment sign, now we are giving the card to the patient and we are asking the patient to hold the card between the thumb and the index finger. Now, we are asking the patient to adduct the thumb and hold the paper. Now, in the case of normal ulnar nerve, yes, the patient hold the card. The case of ulnar nerve injury, the patient hold the card, but the point is how he is holding the card. That is very important. Now, patient flex the interphalangeal joint of the thumb and then he will hold the card. So, patient have compensatory flexion of the interphalangeal joint of the thumb and then he will hold the card. That is our Froment sign. Clear? So, Froment sign is ulnar nerve injury. Patient is not able to use adductor pollicis muscle. We are checking adductor pollicis muscle and the patient compensatory flex the interphalangeal joint of the thumb and then he hold the card. Now, what is a clinical deformity you see in the case of ulnar nerve injury? Now, patient will have partial claw hand. We see that. So, now we know the answer. Ulnar nerve injury. Okay. Now, what are the muscles supplied by palm and the forearm? I told you already. Now, what are the clinical features? Please remember partial claw hand. Partial claw hand. What is partial claw hand? Claw hand is nothing but extension of metacarpophalangeal joint and the flexion of interphalangeal joint. This is the claw hand. Now, partial claw hand involving only the little finger and the ring finger. Okay, index finger and middle finger is not affected. Why? Because lumbricals 1 and 2 are supplied by median nerve. Okay. Now, what about the Froment sign? Froment sign is nothing but compensatory flexion of interphalangeal joint of the thumb. Right. Now, see this diagram. Again, one more thing. Now, we are seeing the complete claw hand. Now, in the case of complete claw hand, yes, the complete claw hand is seen in median nerve plus ulnar nerve injury. When both nerves are affected, the patient will have complete claw hand. Okay, right. Now, see the next question. The 30-year-old male fell from the motorcycle and he had a fracture of the midshaft of the humerus. Now, what is the nerve affected? Now, what is meant by low radial nerve palsy, pin palsy, muscle supplied pin? So many questions are there. Now, first and foremost thing, now what is the nerve affected here? Fracture of shaft of the humerus. I told you the radial nerve is passing in the spiral groove of the humerus. Spiral groove is present in the shaft of the humerus. Very good. So, now shaft of the fracture means radial nerve involvement will be there. So, fracture of the shaft of the humerus with the radial nerve involvement, that fracture is called Holstein-Lewis fracture. That is our Holstein-Lewis fracture. Okay, right. So, now we have to know some basics about the radial nerve. So, radial nerve, it is a branch of posterior cord, we know already. It is the mixed nerve, root value C5, C6, C7, C8, T1. Now, the radial nerve which is entering the forearm, back of forearm, by passing through the lower triangular space, this one. It is formed in the axilla only. Now, in the axilla, radial nerve will give branch to long head and middle head of triceps. After passing through the lower triangular space, radial nerve is passing in the spiral groove. Along with the radial nerve, in the spiral groove, one more artery is passing. What artery? Profunda brachiae artery. Profunda brachiae artery. Okay, yes. These two structures we are seeing. Very good. Now, radial nerve here in the spiral groove, which gives branch to again medial head of triceps and lateral head of triceps. Now, an important point is the branch to medial head of triceps descending down, and it also supplies this muscle. What muscle? Our anconeus muscle. So, anconeus muscle is supplied by nerve to medial head of triceps. Is that clear? Yes. See here, nerve to medial head supplies anconeus. Now, after supplying these muscles, the radial nerve come to front of the arm in the lower lateral aspect. Here, the radial nerve is present between these muscles. What are the muscles? This is brachialis muscle. This is our brachioradialis muscle. And lateral to that, we also have extensor carpi radialis longus. So, radial nerve give branch to brachialis, brachioradialis and ECRL muscle. We give branch to these three muscles here. Now, very important point is below the elbow joint, radial nerve is dividing into superficial branch and the deep branch. This is the radial nerve, and below the elbow joint, see the elbow joint, below elbow joint, radial nerve dividing into, this is superficial branch and this is the deep branch. Okay. Now, superficial branch is a sensory branch. Superficial branch is a sensory branch, and deep branch is our motor branch. Superficial branch, sensory branch, and deep branch is a motor branch. Is that clear? Shall we proceed? Now see the deep branch. Now the deep branch is piercing the supinator muscle and goes to posterior compartment of forearm. And the posterior interosseous nerve supplies all the muscles in the posterior compartment of forearm except three muscles. What are those? Our brachioradialis muscle, ECRL muscle and anconeus muscle. Except these three muscles, remaining muscle, entire muscle in the posterior compartment of forearm is supplied by our, very good, our posterior interosseous nerve. I told you brachioradialis and our extensor carpi radialis longus and anconeus muscle. Now, except these muscles, remaining all muscles, extensor carpi radialis brevis, extensor digitorum, and then extensor digiti minimi, extensor carpi ulnaris, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis, supinator, all the muscles are supplied by our posterior interosseous nerve. Right. Now, next one. Now, the patient is having pin palsy. Now, what will be the deformity we'll see in the patient? Now, in the case of pin palsy, extension of elbow is normal. Why? Because triceps is normal. Triceps maintain the extension. Very good. Extension of wrist is normal. Again, why? ECRL muscle is normal. This muscle maintains the extension of wrist. And the extension of interphalangeal joint is normal. Again, lumbricals and interosseous will do that. Okay. So, in the case of pin palsy, the only extension is lost. Loss of extension of metacarpophalangeal joint. If this movement is lost, then the patient is said to have finger drop. In the case of pin palsy, wrist drop is not seen. So, in the case of pin palsy, the patient will have finger drop, not a wrist drop. Old AIMS question, more chances to ask in our coming exam. Right, now come to, yes, next page, and here we are seeing the questions. Now we are going to write answer for all these questions. Now in the fracture of shaft of the humerus, what is the nerve affected? I told you, radial nerve. Now what is the meaning for the word low radial nerve palsy? See, low radial nerve palsy means radial nerve injury below the elbow joint, but before dividing into superficial and deep branch. That is the low radial nerve palsy. Low radial nerve palsy means injury to the radial nerve below the elbow joint, but before dividing into, yes, superficial branch and deep branch. So now in the case of low radial nerve palsy, superficial branch is affected, deep branch is affected. So patient will have motor loss and also sensory loss. In the case of low radial nerve palsy, sensory loss is seen. Why sensory loss? Because superficial branch of radial nerve is involved. Right, pin palsy I told you. Posterior interosseous nerve palsy, yes. Now all the muscles in the posterior compartment of forearm will be affected except three muscles. Our anconeus, brachioradialis, ECRL muscle. Now in pin palsy, what is the deformity you will get? Only one movement will be lost. Which movement? Loss of extension of metacarpophalangeal joint. Okay? Right. So patient will have what drop? Finger drop. Now if you want to ask any question, a clinical question for the posterior interosseous nerve injury, they will give this only. The patient is brought to emergency department with a history of trauma to the right upper limb. Extension of metacarpophalangeal joint is lost. No wrist drop. No loss of extension of interphalangeal joint, plus no sensory loss. No sensory loss. This is the clue they will give for posterior interosseous nerve palsy. Okay? Right. Now, see the next question. A 30-year-old male involved in the automobile accident presents with arm and he cannot abduct up to 90 to 180 degree. So 90 to 180 degree means overhead abduction. The patient is not able to do overhead abduction of the shoulder joint. Now what are the muscles involved in the overhead abduction? Now overhead abduction is done by, very good, trapezius muscle, which is assisted by serratus anterior muscle. Now trapeze is applied by, very good, spinal part of accessory nerve. Spinal part of accessory nerve also supplies sternocleidomastoid muscle. Serratus anterior supply the long thoracic nerve. Supplied by long thoracic nerve. Okay? Right. Now we know about overhead abduction done by trapezius serratus anterior. Okay. Now which muscle initiate the abduction of shoulder joint? That is 0 to 15 degree. We have one muscle. What muscle? Supraspinatus muscle. Supraspinatus muscle initiate the abduction of shoulder joint. In the recent FMG exams, we are getting questions repeatedly about supraspinatus syndrome. Supraspinatus syndrome means the patient is not able to initiate the abduction of the shoulder joint. Now supraspinatus supplied by suprascapular nerve. Okay. Now only one thing is left. Now what about 15 to 90 degree abduction? 15 to 90 degree abduction is done by, very good, middle fibers of deltoid or acromial fibers of deltoid that will do the abduction of shoulder joint, and deltoid is supplied by axillary nerve. Axillary nerve also supplies deltoid and teres minor. Okay? Right. So these are the points you have to know about the abduction of the shoulder joint. Right. Now see the next question. A person while skiing catches a tree to stop and suffered hyperabduction injury. So in the question we have the clue hyperabduction injury. So whenever the patient is suffering hyperabduction injury, then what is the structure? What is the nerve affected? What is the root affected? Now hyperabduction injury, which in turn result in Klumpke's palsy. Very good. So Klumpke's palsy is the lower trunk injury. Klumpke's palsy is the lower trunk injury. Lower trunk of the brachial plexus is formed by C8 and T1. Very good. Now C8 and T1 fibers supply the muscles of palm. So palm muscles will be paralyzed. So what are the nerves affected? C8 and T1 fibers of median nerve and the ulnar nerve will be affected. Now what will be the deformity seen in this patient? Now in the case of Klumpke's palsy, patient will have median nerve and ulnar nerve, both are affected. Just now I told you. In the case of the complete injury of median nerve, ulnar nerve, all the muscles in the palm will be paralyzed. So patient will have, very good, complete claw hand. T1 fiber also affected. T1 sympathetic fibers will be involved, which in turn result in one syndrome. What syndrome? Horner syndrome. Very good. So patient also have Horner syndrome. Now recent question, 2022 November INACT question. Last November INACT we got this question. Klumpke's palsy features. What are the main features? Main feature is the patient will have claw hand greater than Horner syndrome. Why claw hand is the best answer, sir? See, complete claw hand is seen only if both roots, C8 and T1 fibers are involved. Hernia syndrome, it is a root involving only T1. What is Klumpke's palsy? It is a palsy involving C8 and T1 root. So what is the best answer? Complete claw hand greater than Hernia syndrome. 2022 November INACET question. Right, now we have one differential diagnosis for this. I told you Klumpke's palsy is a lower trunk injury. We also have upper trunk injury. That is our Erb's palsy. Now what is the clinical clue they will give you whenever they want to ask any question about Erb's palsy? Patient is falling on their shoulder. Whenever there is an increase of angle between the neck and the shoulder, the patient will have Erb's palsy. What are the nerves affected? In the Erb's palsy, mainly 3 nerves. Musculocutaneous nerve, axillary nerve, and suprascapular nerve. These are the nerves affected in the Erb's palsy. Okay? Right. Now, what is a deformity you see in the Erb's palsy? Deformity seen in the Erb's palsy is policeman's tip deformity. Policeman's tip deformity. Right. Now, hyperabduction injury. What are the possible questions we can expect? What are the roots affected? C8 and T1 fibers of median nerve and ulnar nerve will be affected. What are the muscles affected? Muscles of palm will be affected. What is the deformity? Complete claw hand greater than Hernia syndrome. What is Erb's palsy? Upper trunk injury. What are the muscles and nerves affected in the Erb's palsy? Now, I told you musculocutaneous nerve, axillary nerve, and suprascapular nerve will be affected. Now, what are the muscles affected? Suprascapular nerve supplies supraspinatus, infraspinatus. These 2 muscles will be gone. Axial nerve supplies deltoid muscle, teres minor. Musculocutaneous nerve supplies biceps, brachialis, and coracobrachialis. Now, an important point is coracobrachialis not affected in the Erb's palsy. Why? Because coracobrachialis is supplied by musculocutaneous nerve with root value C5, C6, C7. C7 root also supplies coracobrachialis. So, coracobrachialis is not affected. Now, what is the deformity you see in the Erb's palsy? Policeman's tip deformity. Now, policeman's tip deformity, the shoulder joint will be adducted and medially rotated. Now, what about the elbow joint? Elbow joint is extended. What about the forearm? Forearm is pronated. This is the deformity you see in the Erb's palsy. Okay. Now, see the question. 60-year-old female came to emergency department with the complaints of swelling below and lateral to pubic tubercle. Right. So, they gave only one clue, below and lateral to pubic tubercle. That is the clue. The patient is having some swelling below and lateral to pubic tubercle. And one more clue they gave, the patient is female. So, we got 2 clues. So, what is the structure present below and lateral to pubic tubercle? Now, if the swelling is present above and middle to pubic tubercle, then what will be the answer? That is what we are going to see now. Now, see here. Now, femoral ring, that is a ring which is present below and lateral to pubic tubercle. Now, what about superficial inguinal ring? Superficial inguinal ring is present above and medial to pubic tubercle. So, superficial ring is present above and medial to pubic tubercle, whereas the femoral ring is situated below and lateral to pubic tubercle. This is our pubic tubercle, and below and lateral to pubic tubercle, our femoral ring is present. Above and middle to pubic tubercle, our superficial ring is present. Okay, right. So, whenever they want to ask any question about the femoral hernia or inguinal hernia, they will use this clue only. So, whenever they want to ask any question about inguinal hernia, the patient comes to you, the doctor, emergency department, with the complaints of swelling in the groin, which is above and medial to pubic tubercle. Again, important point, inguinal hernia most commonly seen in male. Femoral hernia, it is most commonly seen in female, because femoral ring is much wider in female. So, femoral hernia is most commonly seen in female. Okay, right. So, now what is the boundary for femoral ring? So, boundary of femoral ring, another important question for INACET. So, femoral ring, it is the opening at the upper part of the femoral canal. Now, boundary of femoral ring, in the front side, anteriorly, inguinal ligament. On the back side, posteriorly, we have a pectineus muscle and pectineal ligament of Cooper. Medially, we see the lacunar ligament. Laterally, femoral vein. This is the boundary for the femoral ring. Very important. Okay, right. Now, what about the superficial ring? See, superficial inguinal ring. Superficial inguinal ring, I told you, it is present above middle to pubic tubercle, and the superficial inguinal ring is a defect in. It is a defect in external oblique aponeurosis. Please don't forget. Now, what about the deep ring? Deep ring, it is the defect in fascia transversalis. Deep ring is a defect in fascia transversalis, and another important point is deep ring, it is acting as the inlet of the inguinal canal, and deep ring is situated 1.25 centimeter above the midinguinal point. 1.25 centimeter above the midinguinal point. So these are the various points you have to know about this area. Okay, right. Now see the question. Now, patient 60-year-old female came to emergency department with the complaints of swelling below and to pubic tubercle. What is the posterior boundary of the opening through which the hernia occur? So, the patient is having femoral hernia. The hernia is occurring through femoral ring. The posterior boundary of the femoral ring is pectineus muscle and the pectineal ligament of Cooper. Now, superficial ring relation to the pubic tubercle. I told you above and medial to pubic tubercle. Femoral ring boundary, we know. Anteriorly, inguinal ligament. Posteriorly, pectineus muscle and pectineal ligament of Cooper. Medially, lacunar ligament. Laterally, femoral vein. Fine. So now, see the next question. The patient with deep knife wound in the buttock walks with a waddling gait, and it is characterized by pelvis falling towards the right side at each step. So the clue is the patient is having waddling gait and the pelvis is sinking on the right side. That means, yes, the patient is having Trendelenburg sign, positive Trendelenburg sign. Now, which muscle will do that? Which nerve involvement result in this condition? Yes, our gluteus medius and minimus muscle supplied by superior gluteal nerve. So, in the case of superior gluteal nerve injury, gluteus medius and minimus muscle won't work. Now, what this muscle will do? These muscles prevent the sinking of pelvis on the unsupported side. Now, in the case of superior gluteal nerve injury, these two muscles will not work. So, the pelvis will sink on the unsupported side when the patient is standing on the paralyzed side. And this image is very important. So, they can give you image-based question. Okay. Right. So, this Trendelenburg sign positive is due to involvement of gluteus medius and minimus muscle and superior gluteal nerve injury. Fine. Okay. Now, what are the other questions can be asked? Now, if you check any paper from 2017 up to 2022, we are getting one question from the gluteal region. In the INACT exam, I am saying. One question for sure from the gluteal region in the INACT exam. Now, even for coming 2023 May INACT, you get one question for sure. And the next December exam also, you get one question for sure. So, now what are other questions you may get? Now, nobody is going to ask the origin for these muscles. Our gluteus medius and minimus muscle, yes, they take origin from the ilium bone. Gluteus medius and minimus muscle, they take origin from ilium bone. Now, the point is the insertion. See, gluteus minimus muscle is attached to the, this is greater trochanter. This is lesser trochanter. Now, anterior surface of greater trochanter which receives gluteus minimus muscle. Now, what about the gluteus medius, sir? Gluteus medius, lateral surface of greater trochanter. Lateral surface of greater trochanter, yes, which receives our gluteus medius muscle. Now, what about the lesser trochanter, sir? The lesser trochanter, only one muscle, our iliopsoas muscle. Okay. Now, what about gluteus maximus muscle? 2 times we got this question back to back. Gluteus maximus muscle attached to this one. This is our gluteal tuberosity. So, gluteal tuberosity which receives gluteus maximus muscle. Okay. Right. Now, what is the action of the muscle attached to the marked area? They gave the marking in the gluteal tuberosity. Now, action of muscle attached to the marked area. What is action of gluteus maximus muscle? Gluteus maximus muscle cross the hip joint on the back side. So, gluteus maximus muscle do extension, lateral rotation, and also abduction of the hip. Gluteus maximus muscle having three actions. Gluteus maximus muscle supplied by inferior gluteal nerve. Gluteus medius and minimus muscle, they do abduction of the hip joint plus medial rotation of the hip joint, medius and minimus muscle. Okay, right. Again the diagram, yes, we are seeing the clear view of gluteal tuberosity. Very important image. Again you may get the question. Now what is the answer for this question? Now there are so many questions to ask from this clinical stem. Now first point, the patient in this patient, the pelvis is sinking on right side. That means pelvis is sinking on right side means the patient is standing on the left side. Now what is Sutherland-Berg sign? When the patient will have waddling gait, the pelvis will sink on the unsupported side when the patient is standing on the paralyzed side. So now patient pelvis is sinking on right side means this is unsupported side. So patient is standing on the paralyzed side. Which is paralyzed side? Yes, left side is a paralyzed side. Left side, superior gluteal nerve injury. Now what is the first question? Which is the sound side? Which is side is normal side? Our right side is normal side. Right side superior gluteal nerve is normal. Okay, right. Now what are the muscles affected? Muscles affected are gluteus medius and minimus muscle. What is the nerve? Superior gluteal nerve. What is the action of these two muscles? Abduction and medial rotation. Attachment of these muscles, I told you, in the great trochanter, anterior surface and lateral surface. Right. Now see the next question. While playing the football, the 19-year-old college student receives a twisting injury to his knee from the lateral side. Which of the following conditions most likely has occurred? Now see here, the patient is having twisting injury on the lateral side. Now this is the image of the knee joint. Okay. Twisting injury to the knee joint from the lateral side. So patient is having the injury here on the lateral aspect of the knee joint. Now due to this injury, the femur and the tibia, they move more medially. If they move more medially, they in turn damage the medial collateral ligament. So patient will have tear of medial collateral ligament. Now the medial collateral ligament is very close to medial meniscus. Okay. Now again close to that we have the ACL. So whenever there is a twisting injury to the lateral aspect of the knee joint, these three structures are affected. See here, a severe blow on the lateral aspect of the knee joint when the patient planted his sole firmly on the ground, which in turn move the femur and tibia more medially, tear of medial collateral ligament, medial meniscus and the ACL. Now this condition is called unhappy triad or terrible triad. Okay, right. Now see the lateral meniscus. Now lateral meniscus and the lateral collateral ligament, we have some gap. Now that gap is transmitting the tendon of popliteus. So tendon of popliteus is present between lateral collateral ligament and the lateral meniscus. Is that clear? Right. So now in the exams they will ask you, what is the most commonly affected meniscus? The most commonly affected meniscus in the knee injury is our medial meniscus greater than lateral meniscus. Again why? Because medial meniscus is immobile, which is fixed to the surrounding capsule. Whereas lateral meniscus, it is saved by the tendon of popliteus. Okay? Right. Now while playing football, 19-year college student received twisting injury to his knee from lateral side. Which of following condition most likely to occur? Now what are the structures affected? I told you the patient will have unhappy triad. So unhappy triad means medial collateral ligament, medial meniscus and ACL will be affected. What is the most commonly affected meniscus? The most commonly affected meniscus is medial meniscus greater than lateral meniscus. Now what about the cruciate ligament attachment? See, cruciate ligament, we have two, anterior and posterior cruciate ligament. So anterior cruciate ligament and the posterior cruciate ligament, they are named as anterior and posterior by their attachment to tibia. So anterior cruciate ligament, it is starting from anterior part of intercondylar area of tibia. I am simply writing anterior tibia, and which goes to the posterior part of the femur. ACL will go to the lateral condyle of the femur. Posterior part of the lateral condyle of the femur. Now PCL, it is starting from posterior part of the tibia and it comes to anterior part of the femur. Now anterior part of femur comes to which condyle? Medial condyle. So ACL, tibial attachment, anterior part of intercondylar area of tibia. PCL, posterior part of intercondylar area of tibia. Now what about the ACL, femur attachment? It goes to lateral condyle, postero-superior aspect. Now what about our PCL? PCL, antero-inferior aspect of the medial condyle of the femur. So please remember this attachment. Yes, now that's all about that question. Now come to next question. A 60-year-old man came to emergency department and his angiogram exhibited that arteries accompanying the great cardiac vein is affected. So the question is, they are asking the structures accompanying the great cardiac vein. So many things to ask from this. They can ask you the arteries accompanying the great cardiac vein. Great cardiac vein is a tributary to coronary sinus. What are all the tributaries to coronary sinus? What are the veins not draining into coronary sinus? Coronary sinus derived from the other tributaries of coronary sinus, your middle cardiac vein, small cardiac vein. Now, is there any accompanying structure for these veins? So many things to ask. Very important, high yield topic. Now, see the diagram. Now, this is our coronary sinus. So, coronary sinus is derived from embryology, you have to know. It is coming from the left horn of the sinus venosus. The left horn of sinus venosus will obliterate and form the coronary sinus. The coronary sinus opens into posterior smooth wall of right atrium. The posterior smooth wall of right atrium receives three veins: superior vena cava, inferior vena cava, and the coronary sinus. Now, this coronary sinus tributaries, what are the tributaries? We have great cardiac vein, tributary, and in the diagram we are seeing middle cardiac vein. Now, the two more tributaries are posterior vein of left ventricle and the oblique vein of left atrium. Right, these are tributaries. So now you have to know the accompanying structures for these veins. Now the great cardiac vein is accompanying the anterior interventricular artery and the circumflex artery. Okay, right. Now our middle cardiac vein is accompanying the posterior interventricular artery. Okay, and our small cardiac vein is accompanying the right coronary artery. So please don't forget these arteries accompanying the veins. So middle cardiac vein is accompanied by posterior interventricular artery. Great cardiac vein accompanied by two arteries, anterior interventricular artery and the circumflex artery, and small cardiac vein accompanied by right coronary artery. Okay, right. Now see the question. Now structures accompanying the great cardiac vein. I told you anterior interventricular artery and the circumflex artery. Structures accompanying the middle cardiac vein, posterior interventricular artery. What are the tributaries of coronary sinus? I told you, remember 5 tributaries. Okay, what are those? Great cardiac vein, middle cardiac vein, small cardiac vein, posterior vein of left ventricle, and the oblique vein of left atrium, which is not a tributary to the coronary sinus, that opens directly into the anterior wall of the right atrium. Any guess? Very good. Anterior cardiac vein. It is not a tributary. I'll show you here. Now, anterior cardiac vein, see here, these veins. They open directly into the anterior wall of right atrium. They're not into the coronary sinus. Now, coronary sinus derived from, I told you already, left horn of the sinus venosus. Right. Now, see the next question. The newborn diagnosed to have congenital diaphragmatic hernia. Now, what is the most common congenital diaphragmatic hernia? See, the most common congenital diaphragmatic hernia is our Bogdala hernia. To know about Bogdala hernia, we have to know about the sources for diaphragm. Diaphragm is derived from 4 sources. What are those? Contribution from body wall, cervical somites, number 1. Contribution from pleuroperitoneal membrane. contribution from septum transversum and the contribution from esophagus, the mesentery around the esophagus. These are the 4 sources for the development of diaphragm. Very important theory you have to know. At the same time, image also they will ask you. Okay, right. Now, in that, please underline pleuroperitoneal membrane. Sometimes there is a defect in pleuroperitoneal membrane, which in turn result in the persistence of pleuroperitoneal canal. Now we have a communication between the abdominal cavity and the thoracic cavity, through which the abdominal contents herniate into the thoracic cavity. So now we have one hernia. What hernia? Bogdala hernia. So Bogdala hernia is due to, very good, due to defect in pleuroperitoneal membrane. Okay. Now this hernia is most common congenital diaphragmatic hernia. Now where you see this one, left side is more common than the right side. Now where you see the defect, this is anterior, this is posterior, this is medial and this is lateral. The gap or defect in the Bogdala hernia is posterolateral. This itself a question. The defect or gap in Bogdala hernia is anterolateral, anteromedial, posterolateral, posteromedial. Likewise, they'll give you the question. Okay. So gap is posterolateral. Now we have one differential diagnosis, Morgagnian hernia. Morgagnian hernia is due to, this defect is due to, this hernia is due to the enlarged space of Larry. Enlarged space of Larry. Now where this hernia, the gap is in the front side and more towards medial side. The gap in Morgagnian hernia is anteromedial. And the Morgagnian hernia is most commonly seen in right side greater than left side. Okay, right. So now the newborn diagnosed to have congenital diaphragmatic hernia. Okay, the most common congenital diaphragmatic hernia is our Bogdala hernia due to defect in pleuroperitoneal membrane. Most common side, left side greater than right side. And where is the gap? Posterolateral. Posterolateral. This is the gap of the Bogdala hernia. We know how to differentiate from the Morgagnian hernia. Morgagnian hernia more common on the right side and the gap is anteromedial. That is due to enlarged space of Larry. Okay, space of Larry is a space between the sternal and the causal organs of diaphragm. Sometimes the space of Larry may be enlarged. Now through that the abdominal contents will herniate. Okay, yes. These are the points you have to know about our congenital diaphragmatic hernia. Another important topic. Now see the next question. 25-year-old presents with pain in his groin that has been increasing in nature over the past few weeks. Now he is found to have degenerative malformation of conjoint tendon. So they are asking question about the conjoint tendon. Now who will form the conjoint tendon? Okay, that is the point. So conjoint tendon is formed by, very good, our internal oblique muscle joining with the transverse abdominis muscle and they will form the conjoint tendon. See here, the conjoint tendon is formed by, now this one I am talking about. Now this is our external oblique muscle and the internal oblique muscle and the transverse abdominis, they join together to form the conjoint tendon. Okay, right. So now what is their relation to inguinal canal? Now inguinal canal relation for the conjoint tendon. Now see here, now this is a diagram, we are seeing the inguinal canal. Now this is our deep ring or internal ring and this is superficial ring. Okay, superficial ring and we are seeing the canal here. This is our canal. Yes. Now this is posterior wall of the canal. This is anterior wall of the canal. This is lateral aspect and this is medial aspect. Okay, right. Now the internal oblique muscle and the transverse abdominis muscle, they are forming roof of the canal. Okay, and these two muscles, their tendons, they join and they form conjoint tendon and they come like this. Now this is our conjoint tendon. So conjoint tendon is giving strength to which wall? Now what is the structure giving strength to the posterior wall? Posterior wall of the inguinal canal is formed by fascia transversalis and this internal oblique muscle and the transverse abdominis muscle, they form conjoint tendon. Now the conjoint tendon giving strength to posterior wall on the on the medial aspect. That is very important. Okay, so conjoint tendon giving strength to posterior wall on the medial aspect. Is that clear? Any doubt? No. Now what about the anterior wall? Now anterior wall is formed by our external oblique muscle, and the anterior wall is strengthened laterally by our internal oblique muscle. Now what about the roof? Roof I told you already, internal oblique and the trans abdominis muscle. What about the floor? Floor is formed by the inguinal ligament. These are the boundaries of the inguinal canal. Okay. Now this conjoint tendon, after the formation, which is passing in front of the Hasselbalch's triangle. Now this is our rectus abdominis muscle, and this is our inferior epigastric artery, and the conjoint tendon is passing in front of Hasselbalch's triangle. Now weakness of conjoint tendon, which in turn result in hernia through the Hasselbalch's triangle. Hernia through Hasselbalch's triangle is called direct inguinal hernia. So weakness of which of the following leads to direct inguinal hernia? Answer, conjoint tendon. Recent NEET question, 2023 NEET question. Okay, right. So now see the question. So we know the answer. Conjoint tendon is formed by our internal oblique and transverse abdominis. Relation to inguinal canal, conjoint tendon is giving strength to posterior wall on the lateral aspect. Weakness of conjoint tendon, which in turn result in direct inguinal hernia. Now, what is the relation of inferior epigastric artery to the direct hernia? Now, see here. Now, this is our rectus abdominis muscle, and below is the inguinal ligament, and this is our inferior epigastric artery. Now, this is our Hasselbalch's triangle. Okay. I told you direct hernia occurs through Hasselbalch's triangle. Now, what is the relation of inferior epigastric artery to the Hasselbalch's triangle? What is the relation of inferior epigastric artery to direct hernia? So, inferior epigastric artery, it is on the lateral side to the direct hernia, to the Hasselbalch's triangle. Clear? So, inferior epigastric artery is lateral to direct hernia, and the opposite is for our indirect inguinal hernia. Indirect inguinal hernia, inferior epigastric artery is medial. Okay, don't forget. Right, these are the points you have to know about this topic. Now come to next question. 43-year-old woman is admitted to the hospital because of deep abdominal pain in the epigastric region. On examination, it is observed that retroperitoneal infection erodes the artery that runs along the superior border of the pancreas. So now they are asking the structure which is running in the superior border of pancreas. So pancreas relation is very important. We have a vessels running behind the head of pancreas, running behind the neck of pancreas, running in front of uncinate process, vessels in the upper border of the body, behind the body. So anything can be asked. So the relation is very, very important. So now see the diagram. Now this is the image of the pancreas. Now pancreas, the head of pancreas is present within the concavity of the duodenum. Very good. Now in the head we have one small extension. That extension is called uncinate process. Now in front of uncinate process we have superior mesenteric artery and the superior mesenteric vein. Okay, right. Now behind the neck, after the head of pancreas, this is our neck, and behind the neck of pancreas, portal vein formation will occur. Important event. Now body of pancreas is going horizontally from the abdominal aorta and crossing the left kidney anteriorly. And finally tail of pancreas is present in the leno-renal ligament. Okay, these are various parts of the pancreas. Now see the relation. Now I told you behind the head of pancreas, our retropancreatic part of common bile duct is present. Please remember that. Now apart from that, behind the head we have three veins. This is number 1, number 2 and number 3. So behind the head of pancreas, posterior to the head of pancreas, right renal vein, inferior vena cava and the left renal vein. The diagram I marked inferior vena cava as number 1, right renal vein as number 2 and left renal vein as number 3. Behind the head of pancreas we have three veins. Okay, right. Now this is our uncinate process. Now in front of uncinate process we have superior mesenteric artery and the superior mesenteric vein. superior mesenteric artery and superior mesenteric vein, they are crossing the uncinate in front. Very important relation. 2020 NEET exam question. They gave the patient is having carcinoma in the uncinate process. Which of the following vessel will be affected? Superior mesenteric artery and superior mesenteric vein. Okay, right. Now same superior mesenteric vein go behind the neck of pancreas and joins with the splenic vein and in turn forms portal vein. So behind the neck of pancreas, posterior to the neck of pancreas, portal vein formation in the upper part, superior mesenteric vein in the lower part. Please remember, superior mesenteric vein is anterior to the uncinate. The same superior mesenteric vein is posterior to the neck of pancreas. Okay, right. Now 2 more points. What about splenic vein? Splenic vein is passing behind the body. What about the splenic artery? Splenic artery is at the upper border of the body of pancreas. Splenic artery is at the upper border of body of pancreas. Splenic vein is behind the body of pancreas. Okay, right. So these are the points you have to remember for the relations of pancreas. So now what is the artery at the upper border of the pancreas? Our splenic artery. Structure related to uncinate process, superior mesenteric artery, superior mesenteric vein. Vein posterior to the head of pancreas, right renal vein, IVC, left renal vein. Structure posterior to the body of pancreas, splenic vein. Veins posterior to neck of pancreas, superior mesenteric vein and portal vein. Now portal vein is formed by superior mesenteric vein joining with splenic vein. Very good. Right. So one last question for this session. Right. So now 32-year-old male patient with a motor vehicle accident presented to the casualty with a pelvic fracture. His vitals are stable, but he is unable to pass urine. On examination, he has a blood at the penile meatus. What is the most likely site of urethral injury? So now the question is, the patient is having pelvic fracture. So pelvic fracture means which urethra is ruptured? Pelvic fracture means, please remember, membranous urethra is affected. Membranous urethra. That one word is enough. Pelvic fracture means membranous urethra. Now what is the clue they will give for spongy urethral injury? Whenever they want to ask any question about the spongy urethral injury, they will give you the patient is suffering straddle injury. So spongy urethra affected in the case of straddle injury. Spongy urethra rupture in the straddle injury. Membranous urethra rupture in the pelvic fracture. Now what are the areas the urine will extravasate? Now in the case of spongy urethral rupture, the urine will go to superficial perineal space. Now from there it will go to anterior abdominal wall. They have a communication in the front side. Now the urine also go to penis and scrotum. These are the 4 areas the urine will extravasate in the case of rupture of bulbar urethra or spongy urethra. Okay, right. Now what about our membranous urethral rupture? See, membranous urethral rupture means the urine extravased to deep space and the urine also go to the space around the bladder and the prostate. That space is called space of Retzius. One last point is, now is there any chance for urine to spill into the peritoneal cavity? Now the urine go into the peritoneal cavity only in the case of bladder injury. The urine will not go to peritoneal cavity in the case of urethral injury. So please note down this point. Urine extravased into the peritoneal cavity only in the case of bladder rupture. Only in the case of bladder injury. Is that fine? Right. So please don't forget this point. So now we know the answer. Pelvic fracture. Now membranous urethra rupture. The urine extravased to membranous urethra is a content of deep space. So urine will go to deep space and the urine also go to space of Retzius. Okay. Now what about straddle injury? Straddle injury means spongyurethral rupture. In the case of spongyurethral rupture, urine go to superficial perineal space and then scrotum, penis, and also the anterior abdominal wall. Okay. Yes. So these are the points you have to know about this topic. So that's all, guys. So these are some important clinical stems. These are some important areas where we are getting questions in the INA CET or NEET exam. I hope you had a good time. So thank you so much for joining with me. Once again, this is Dr. Raviraj signing off from this. Thank you so much and see you in the next session.